A very good morning to all of you. Welcome to another episode of Sri Knowledge Academy weekly Sunday webinar series. Today we have a very interesting topic. Before going into the lecture, let's go to see some housekeeping rules. The webinar link will be open for you to join in from 9 to 9:15 a.m. No late attendees will be permitted to join thereafter. All attendees should have been stayed until the end of the lecture to obtain the e-certificate and the CPD points. Kindly keep your mics and the videos turned off during the time of lecture. If you have any questions, you can type it in the chat box or you can directly ask at the end of the lecture from the lecturer himself. So let's move on to the lecture. Today our topic is Unveiling the Complexity, Understanding Cauda Equina Syndrome. Today our lecturer is Dr. Balakumaran Thangarajah, is the consultant orthopedic surgeon in District General Hospital, Trincomalee. He has a fellowship in spinal surgery and he was the acting consultant orthopedic surgeon in NHSL from August 2021 to 2023. Dear sir, over to you to conduct your timely lecture. Thank you very much.
Good morning, all of you. Thank you for giving a chance to present this Cauda Equina syndrome on this forum. I have to thank Shri for that. I'm willing to present the Cauda Equina syndrome because in Sri Lanka, most of the time, we are missing the actual presentation of Cauda Equina syndromes. Most of the patients are coming after getting all nerve damaged, and the recovery is very less chance. I like to start with the case presentation of this. There's a story. There's one patient admitted in ED, is a middle-aged female graduate teacher having a 5 weeks history of lower back and left buttock pain since heavy weight lifted. It was worse last 3 days and complaining of cramping and dull pain radiating down to the left leg and foot. But her bladder and bowel function was normal. The examination shows the limb tone and reflexes normal, but the knee extension power is 4 out of 5. The reduced sensation is L2 and reduced joint position sense in the right side, grade 2. The next 24 was patient diagnosed with a sciatica and advised to red flag symptoms and sent to home. But next day, numbness developed on her left buttock to the foot and unable to walk due to the pain. She also developed one episode of urinary incontinence. After that, they have taken to the ED again. In the ED seen by RHO at 11:40 p.m., the sensation is altered in both buttocks up to T9 for her examination, is mainly on the left. And she found this anesthetic perineum and reduced anal tone. That time, she had a urinary incontinence without sensation. So the patient history was discussed with the registrar and the MRI planned for next morning. On the next day, constant urinary incontinence overnight, seen by the consultant at 9 a.m. The left side sensory loss L1 to S4, weak hip flexion and knee extension, absent ankle and foot movements. The MRI finally taken at 10:45 a.m. result view on 1:20 p.m. Then they have urgently transferred to the spinal center. The patient arrived at center at 7 p.m. Finally, the decompression done at 11:20 p.m. So what is the outcome of this one? The outcome is poor because it's delayed. So the patient had a urinary, bowel, and sexual dysfunction, left foot drop, limited mobility, subsequent fall, and had a neck of femur fracture. She can't go to the work. So this is the impact of Cauda Equina syndrome in a person. So with this impression, I am entering the topic. So if you see in this public, so police search someone to find, but in this big crowd, how to find a person who they want. So that is a problem, is diagnosing Cauda Equina syndrome as well. Because the most of our primary care physicians, the patients are presenting with a lumbar back pain and radiating pain down. So with that, the Cauda Equina syndrome is very, very less common. So how we are going to diagnose this Cauda Equina syndrome among this lot of back pain presentation. Now we will enter with these questions, we will enter into the contents. So first section, I tried to demonstrate what is Cauda Equina syndrome. It consists of definition, background, pathophysiology, and etiology. The second section consists of clinical features and diagnosis that consist symptom and signs, clinical evaluation, imaging, and diagnosis. The third section having a treatment workup, mainly surgical management and time of the surgery, etc. Finally, the last I have to say about outcomes, so how we are managing post-operatively and how the patient recovery, what is the long-term outcome we have to discuss in that heading. All right, so we will move on to what is Cauda syndrome. By definition, is a neuromuscular and urogenital symptoms resulting from simultaneous compression of multiple lumbosacral nerve roots below the level of conus medullaris. So if you see the background, the radicular pain and or back pain are the common patient presentation to the healthcare professionals, as I mentioned earlier. So the Cauda syndrome is very rare but serious spinal presentation, radicular and back pain that require immediate assessment, investigation, and treatment. If it is unrecognized or surgical treatment is delayed, this must result in a permanent loss of bladder and bowel function, loss of sexual function, and lower limb paralysis. So patient may continue to experience ongoing severe disability despite prompt treatment. But if it is treated before symptoms become severe, this can be reduced and the risk of permanent disability. So we will now we know what is the heaviness of Cauda syndrome. So we will enter into the anatomy and anatomy, physiology, and pathophysiology. Then we can, if you understand these things, we can easily manage the patient. So if you see the anatomy of the Cauda equina, it's called horse tail. That's a French meaning of Cauda equina. So if you see, this is a spinal cord finishing at lower end of the L1 vertebra, and after that, all bunch of nerves, that spinal roots are coming out. This bunch is called Cauda equina. This covered by the dura from the foramen magnum from down to the coccyx. So within the dura, there's a CSF. These cords are suspension by the CSF, and CSF nourish the nutrition to them. So if you see this in this picture, this is the total length of Cauda equina starting from L1 to end start of the coccyx. So these in every segment, they are distributing nerves and supplying the sensation, motor, and autonomic functions. So if you see this cross section of Cauda equina starting from low end to upper, this is L5S1 and this is L2-3. So if you see upper end cross section of Cauda equina, a lot of nerve roots are coming out. The peripheral nerve roots are going out. That means L2-3 or 3-4. It's the central nerve roots are the S1 to S4 and the L5, something like that. So if you're going down, the central nerve roots are coming out when they are leaving from that Cauda equina. So if it is compressing this Cauda equina, the central roots are finally compressing. So if you see the anatomy, the central roots, mainly the autonomic functions, nerves having in the central root. So the compression is very severe only that will cause compression of these central root fibers. So if you see the function, as I mentioned before, the motor function, sensory function, as well as the autonomic function. If you see the sensory, so from the Cauda equina area, the sensation starting from L1 to S4, these all are distributed in the legs. We already know about that and how to examine, we know. And the motor function that's starting from L2 to S4, if we see that there are some joint movements overlap each and other myotome, but if you have easy to understand, that will help to the examination as well. So L2 is mainly hip flexion, L3 is knee extension, L4 is ankle dorsiflexion, L5 big toe extension, S1 ankle plantar flexion, and S2 to S4 external anal urethral sphincter. If you see the autonomic function, that parasympathetics, mainly S2 to S4, coming through the pelvic splanchnic nerve, supply the bladder, bowel, and sexual function. So this is I mentioned this is the nerve fibers coming in center, and if it is compressed, this causes Cauda equina syndrome. So we will going to the pathophysiology now. If you see, this is a common presentation of the sciatic pain. So that means the compression of the nerve roots. How is it occurring? If you see, this is a intervertebral disc having a nucleus pulposus and annulus fibrosis. So if any weaken in the annulus fibrosis causing bulging of nucleus pulposus throughout this and compressing the relevant nerve root. If you see in the disc, there are various places it can be occur, but this common place is a paracentral region. This paracentral disc bulge causing compressing of the nerve root. But if you see, if the defect is in the center, but it's less common compared to the paracentral, that will come and compressing the cauda equina directly. So this is this disc prolapse have a risk of causing a cauda equina syndrome because it's very nicely squeezing the cauda equina, which is very tight. So this is the animation, sample animation showing how the cauda equina compression. So starting from that, it's going inside and compressing the peripheral nerves first. When it's come inside very deep, it's compressing the central nerve as well. So when it's compressing, it will cause inflammation and other pathology. I will describe it later. So this is the pathology slide. So whatever the compression is starting with the mechanical compression. So whatever the causing mechanical compression, first is compress the nerve. With compression of the nerve, it compresses the blood vessels which are supplying the nerve roots. So that cause ischemia of the distal part, as well as these compression of these vessels, and it will compress the venous return as well. So if it is veins are compressing, that cause venous stasis. So altogether making like a compartment syndrome. So that will cause the infraction of the nerve as well as cause inflammation surrounding that region. So we will move into the causes of cauda equina syndrome. So as I mentioned, the most common cause is disc prolapse. So if you see the total number of 100 cauda equina syndrome, the 45 is from the disc prolapse. But if you're seeing the total disc prolapse, that means sciatica pain or radiculopathy patients, only 3% end up in cauda equina syndrome. So now we can see how the percentage of patients are going to the cauda equina syndrome. The second common cause is a trauma, is mainly due to the retropulsion of the fracture fragments, dislocations, or collapse. So example, lumbar burst fractures, it causes compression of cauda equina. The other reasons are the tumors, can be a primary tumor and or metastasis. If you're seeing elderly populations, the metastasis is the most common cause. So that will, the metastasis can be spread out, or it causes again fracture of the vertebra, and that will cause the compression. If you see some examples of the primary tumors, like a myxopapillary ependymoma, schwannoma, or spinal meningioma. Rather than these common causes, some other less common causes are there, like spinal epidural hematoma. Even though it's less common, but it is very important for spine surgeons because it mainly occurring in postoperative. That's maybe due to the aggressive DVT prophylaxis or after neuroaxial anesthesia, or occur in postoperative period with early DVT prophylaxis. So this is little important when we are seeing the post-op patients. We have keep in mind there's a chance of cauda equina syndrome because of surgical procedures. So anything, if it damage any vessels, or if you are not achieving the hemostasis after surgery. Other thing is epidural abscess. These infections can come from the spondylodiscitis or other hematogenous causes that will cause the tightening of the cauda equina. And some other causes like synovial facet cyst and developmental spondylolisthesis, etc., etc. So now we will move into the clinical features and diagnosis. Now we have understand the anatomy, physiology, and the pathophysiology. So with this understanding, we can easily diagnose the cauda equina syndrome. So the cauda equina syndrome, as I mentioned earlier, this have a collection of symptoms and clinical signs, but it doesn't have any pathognomonic features or clinical features to diagnose it. So we have to synthesize from these important clinical symptoms and signs, as well as we have to take an MRI. All together, all three modalities, we have to make a diagnosis. So no single symptoms or sign is pathognomonic is important. We have to keep in mind. If you see the common signs and symptoms, most commonly severe lower back pain. This everyday health professional meeting a patient with lower back pain. And other thing is sciatica. So most of the patient presented to us is a unilateral sciatica. If the unilateral sciatica become bilateral, we have to get alert something wrong. Or sudden onset of bilateral sciatica also is alarming symptoms for Cauda equina syndrome. The third one is a saddle anesthesia and genital disturbance. That's an important alarming feature to think about Cauda equina syndrome. Next thing is a bladder dysfunction. It is a wide variety of symptoms, starting from the painful micturition to painless micturition, and subsequently end up in a urinary incontinence. The third one is a bowel incontinence and sexual dysfunction. The fourth one is a lower extremity weakness. It can become first if the compression starting from the lateral disc, or so if it is end up in a total compression, then patient initially present with the sciatica and sensation loss and weakness, then finally end up in the Cauda equina. But if it is compression starting from the central, the extremity weakness coming later. So the Tandon and Shankaran described three variations of Cauda equina syndrome. So first one is a acute bladder dysfunction with history of low back pain and sciatica. So this one we know because already patients diagnosed with the sciatica, then patient come with the acute bladder dysfunction, then we can easily diagnose. The second one having a chronic backache, sciatica, and gradually progressing the Cauda equina syndrome with the canal stenosis. This is also a long-term history, and we most probably patient in with our follow-up, then we know if it is getting worse, then we can quickly intervene. But the third one is a dangerous because it's a rapid onset without previous history of back problems, is sudden onset of Cauda equina syndrome features. This is the one we are commonly missing. We have to keep an eye to diagnose this one. So from the British Journal of Neurosurgery, they have had a guidelines for the Cauda equina syndromes is mainly emphasizing the red flags. So what is red flag? The red flag is still, this is a danger in everywhere, isn't it? So in the Cauda equina syndrome, we have to see what are the danger features. The definitive red flags are bilateral radiculopathy, progressive neurological deficit in the leg. If it is there, then we have to keep on making alarm to us whether it's a Cauda equina syndrome. Then we have to keep on asking questions to find out whether it's there or not. The second one is a red or white flag symptom. It's an equivocal. So it can be progressed to impaired perineal sensation, impaired anal tone, or urinary disturbance, but it's not specified, but patient randomly saying some disturbance of the urine. The third one is a white flag. White flag means is surrender. So that means the Cauda equina syndrome presentation is late. Then we may have surrender to the patient, to the condition. We can't do much for this patient. So this features are urinary retention or incontinence, fecal incontinence, or perineal anesthesia. So these are little giving some alarm or idea about us, what is the severity of the Cauda equina syndrome presentation. Right, we will move to the warning symptoms. So the National Suspected Cauda equina syndrome pathway in UK, they have suggested the warning symptoms. If it is there, then we have to ask deeper questions to diagnose whether Cauda equina syndrome is there or not. So first one is a difficulty in initiating urine. If the patient complaining to us impaired sensation, urine flow, or difficulty initiating micturition, if it is occurring newly, that means less than 2 weeks, we have to make deeper questioning. And second one is the altered perianal or perineal or genital sensations, mainly S2 to S5. So that is also again new. The third one is a severe progressive neurological deficit in both legs. So we can examine that, and we have to identify and we have to ask further questions. The fourth one is a loss of sensation, the rectal fullness for last 2 weeks. Most of the patients are elderly patient coming and complaining us is if the bladder function is okay, they say, no, I have a constipation. So the constipation is not mean of the bowel dysfunction. So the thing is, bowel dysfunction means the in view of Cauda equina or nerve function, we have to ask about the rectal fullness, whether can you feel you want to go to the toilet or not. So these are specific questions we have to ask for that patient. Other thing is that sexual dysfunction, if it is within 2 weeks, then we have to be very alert. If the patients are coming sciatica-like symptoms, but we couldn't identify any features of Cauda equina, So when we are treating the patient or when we are discharging the patient, we have to safety netting. That means we have to educate the patients what are the alarming symptoms of Cauda equina, and if it is there, then please come to the hospital. So these are the warning symptoms and signs we have to explain. Loss of feeling, pins and needle between your inner thighs or genital, numbness around your back passage or buttocks, altered feeling when you're going to the toilet, when you wipe the paper or when you clean with the water, if you can't feel in the perineal area, or increasing difficulty when you try to urinate, increasing difficulty when you try to stop or control your flow of the urine, and loss of sensation when you pass urine, leaking of urine or recent need to use pads. That one is not knowing when your bladder is either full or empty, inability to stop a bowel movement or leaking, loss of sensation when you pass a bowel motion, change in ability to achieve erection or ejaculate, loss of sensation in genital during sexual intercourse. So any combination of these symptoms, then we educate the patient to immediately seek the medical advice or immediately go to the hospital. Right. If the patients come to the hospital, what we are going to do? So we will check the SLR and cross SLR if it is mainly the disc disease or stretching of the sciatic nerve goes as symptoms. And dermatomal evaluations, it's definitely, I have mentioned before, we have seen sensory and motor neurological grading and evaluation of the perianal sensory disturbance with a pinprick and touch sensation. So when you see these European Spinal Journal, they have found the perianal numbness sensitivity is 82.3% and negative predictive value is 92%. So the next is a digital rectal examination. So when we do the digital rectal examination, we have to see the anal tone and voluntary contraction as well as the involuntary contraction. So the overall correctness of assessing anal tone using DR is limited to 64% only. The sensitivity anal tone predicts is 52.9. Now you can understand mainly if the elderly population come for these symptoms with the anal fecal incontinence or constipations or something wrong, they say if you see the anal tone will be reduced. So that not much indicate as is the Cauda equina syndrome. But the anal wing is giving some clue for us. If anal wing means if you touch the surrounding the anal sphincter, or if you streak it, that will cause contraction of the anal sphincter that we can visible. So most of the patients intact anal wing at the presentation will eventually have a satisfactory recovery of bladder and bowel function. That's a good things to be assessed when we are seeing the patients. The other thing, when you see the patients, if patients already catheterized, then we can do some test for trigone sensitivity. We pull the catheter. So if it is genuine neurological damage, the patient will not feel the catheter. And if it is mainly due to sometimes pain retention, if they are catheterized already, then if you touch the trigone, then patient feel to micturate. So that's give a good idea whether is retention mainly due to pain or retention is due to the neurological damage. So even though we are seeing in the patients purely pain-related retention, which is not uncommon. So the bladder scan. So after the clinical evaluations, we have to go for the bladder scan. This is little giving an idea to us. The ultrasound scan bladder to evaluate the detrusor contractility as well as the post-void residual volume. So if you want to assess the contractility and all, we have to send the radiologist to assess. But in the ward, we can do the post-void residual urine. When we see the patients, if the patients can urinate, then ask them to urinate. After urination, we are assessing the residual volume, is called post-void residual volume. Then with that volume, we can have some idea about the Cauda equina syndrome. According to these journals and a lot of articles regarding this bladder scan, averagely that post-void is less than 200 is CS probabilities of 3.6, very less. But if it is more than 200, it's probably having 43%. So this gives some idea at the level of 200 is giving a good value. Is less than 200 had a negative predictive value is 97. The PVR cutoff value of 200 is a strong predictor for the Cauda equina syndrome. So sensitivity is 94% and negative predictive value is 98%. So what is the conclusion? So blood scanning is useful adjunct for the diagnosis of Cauda syndrome. It had a better negative predictive value than physical examination. So what we can do, so we have done the scan. So how to diagnose from the scan? If the patient able to void PVR is greater than 200, then we are thinking about suspicious of Cauda syndrome. We have to go for urgent MRI. If the PVR is less than 200, then even though there's a strong evidence of Cauda syndrome, that means in the clinical features having a strong evidence, then still we have to go for MRI. If the patient's unable to void but blood scan shows is more than 600, then we have to catheterize immediately. And again, we have to go for the MRI. So why we are catheterizing immediately? If we are not catheterized, the bladder plasticity will go down. So that's called blown bladder. The bladder will not function again. So because of that, we have to immediately decompress the bladder to put the catheter, and we can check the trigone sensitivity, as well as we have to send them to MRI. So up to now, we have seen what is the clinical presentation and what are the assessment, what about the bladder scan. So according to that, we are classifying the presentation of these Cauda syndrome by 3 grading. The first one is a Cauda syndrome suspected. The second one is a Cauda syndrome incomplete. The third one is the Cauda syndrome retention. So if you see one by one, the Cauda syndrome suspected having a bilateral radiculopathy and or subjective sphincteric problems and or subjective perineal sensory changes with no objective evidence of Cauda syndrome. So if you are suspecting people, they have radiculopathy, they say some issues in the passing urine, and they say there's a perineal numbness, but if we examine, everything's normal in the perineum and all, so that is suspicious. When you go, the second category is incomplete. So subjective symptoms, if after examining we also having the objective signs, like means perianal pinprick sensation is reduced, but still they have the voluntary control of micturition. That is important. They have voluntary control of micturition. That is in incomplete grade. So if you see that last stage is a retention. That means subjective symptoms, objective signs as like a incomplete but neurogenic retention of urine with bladder paralyzed and insensate. So this is the last one. So this is difficult to treat. So there's a British Association of Spine Surgeons. They have specifically give the plan for this Cauda syndrome. It's called National Suspected Cauda syndrome pathway. What they are mentioning: a patient presenting with a leg pain and or back pain with a suggestion of new disturbance of the bladder or bowel function or sexual dysfunction or saddle sensory disturbance should be suspected of having a developing Cauda syndrome and should undergo deeper questioning to establish onset of progression and symptoms. So it has to be confirmed in the introduction, but I put later because it has some complicated sentence before understanding Cauda, difficult to understand these sentences. So that's why I put it later. So this alarming symptoms are new within 2 weeks. One of these symptoms, we have to be alert and we have to keep in mind probably Cauda syndrome. Okay, now we will go into the imaging. What is the imaging we are going to do? We will definitely do the MRI, isn't it? The MRI is a critical diagnostic investigations in the management of patient with suspected Cauda syndrome. Standard sequence should be occurred. Keep the patient nil by mouth if requesting an emergency scan, because most of the time after that we have to go for surgery. So the MRI scan must be urgent. So it has to be over any routine or elective cases. Patient has to be escalated. If it is escalated in the local level, we have to escalate it in a consultant level and we have to do urgent MRI. So if there are any absolute contraindications, like if the patient's having a external any metal or something else, then patient can't go for MRI scannings. And so then we have to do the CT scan with the soft tissue sequences. With that evidence, we have to go for the surgery. So the recent guidelines of National Suspected Cauda syndrome pathway in UK, they mentioned that MRI time would be less than 4 hours from the referral. So it's not possible in Sri Lanka, but we can do as early as possible by transferring the patient's proper hospital which having MRI. So this is a one picture just showing the Cauda equina syndrome. If you see in the sagittal MRI, it's the compression of these disc is totally crushing this Cauda equina. Is in the axial section. This is the only space available with this filled by the disc. Right, now we will come again, the picture again. So we think about this is back and radiculopathy patients. We have to find the Cauda equina. Now we are finding one person because we know how to find with the clinical features and the bladder scan and the MRI findings. Okay, now we have diagnosed the Cauda equina syndrome and how we are going to manage. So this is a treatment and workup. So the management is mainly the surgical management is steadfast with the seldom room for any non-surgical option given the natural of Cauda equina syndrome. So mainly we are going for the surgical management. The principle of surgery is minimal retraction of the compromised dural sac and complete removal of the offending disc or osteophyte complex and maintaining the spinal stability. That is important. So the choice of the decompression or decompression with fusion has been considerably debated, but we have to justify whether we only go for decompression because most of these surgeries we are doing middle of the night. So it has to be simple and it has to be quickly symptom relief and quickly relieve the compression. So we have to decide whether need compression alone or decompression alone or decompression with fixation. So why we are going for the fusion or fixation? Fusion should be considered in the situation like recurrent disc herniation, associated instability, large central disc with a narrow canal. If it is a narrow canal, we have to remove the facet joint. So if you're removing the part of the facet joint, the stability will be questioned. So we may need to fuse. Patient also having predominant lower back pain, chronic back pain, that means chronic instability of the spine, then end up in fusion. Other thing is the sagittal facet orientation is, of course, unstable spine after surgery. Then we are thinking about fusion. So this is a sample video saying how the surgery is, how the compression surgery is going on. The skin incision going in one side and spreading out all the muscles. Here the lamina is open. There's in between lamina, there's a ligamentum flavum. So most of the time we are going in a one laminotomy and going inside. If it is a disc compression, we are taking the disc from the one part. Sometimes difficult to taking from one part because there's no room for access the disc for the one side. That time we are going opposite side and both sides we are open and we are getting the disc out. If the compression is very severe, we will go both side laminectomy. Here, this is a sample video just showing the laminectomy of two vertebral level. So if you see these videos, then this is a cross sections or axial sections we can see after taking out and giving a space on this. So what are the adverse effects of the decompression? So if you think about the adverse effect, one is a recurrent disc herniation. So because we are damaging the disc part and we are opening the PLL, so there's a chance of recurrent disc herniation, which is 5 to 24%. And chronic lumbar back pain, mainly due to damaging the disc inside, and there are 3 joints in the intervertebral areas in every vertebra. So one is big disc, other 2 is a posteriorly facet joint. So 3 tripod connections make the spine stable. So if you're losing this one connection, so that will cause severe back pain because unstable. And we are disturbing the PLL as well when we are taking out. So that is also causing chronic lumbar back pain. And that's above causes I mentioned earlier. And if we remove the part of the facet joint with the laminectomy, so we will make more unstable spine. So that will also causing pain, and we may end up in a fixation later. Other things are increased chances of neurological worsening due to manipulative nerve injury is already compromised. This is a big problem because this is already compromised because of very tight. And we also going inside, we have to little manipulate because of the tight space. We don't have space to work. So we are just manipulating. That may damage the nerves and it causes neuropraxia, or sometimes may more damage. It causes chronic nerve pain or radicular pain. And when we are doing these things, when you're manipulating nerves, if you're doing over manipulation and all, it will cause fibrostic healing. So fibrosis around the nerve is cause chronic radicular pain, and it may end up in a progressive stenosis. We have seen how what we are going to do, what is the surgery we are going to do, how to decompress the compression of Cauda equina. The other important thing is the timing of surgery, when we are going to do. The urgency of the surgical decompression has remained a contentious issues in the management of Cauda equina syndrome. The several studies have attempted to define time to intervene following Cauda equina syndrome onset on functional outcomes. General consensus on early intervention for improve outcome for these patients, it will accepted. So deterioration of the function of Cauda equina syndrome patient is continuous and it's progressive. So what we are going to do? So this all evidences showing the outcome and everything's causing a prolonged compression. So the timing is we have to do as early as possible. Next few slides, we will see some evidences to do the early surgery. So in the Spine Journal 2017, they have mentioned the studies aim for the intervention and management of patients with Cauda equina syndrome has an impact on outcomes. This is early intervention of Cauda equina syndrome, regardless of subtype, that means complete, incomplete, or retention, is highly likely would improve the patient outcome. They have taken the retention here because retention is different category. I will come that later. So the getting better with higher, however, with incompletion. So if you see complete and incomplete, if you do urgent surgeries with very less time after presentation, incomplete has higher improved outcome. The timing of intervention did not seem to be matter in traumatic Cauda equina syndrome compared with the degenerative. So this is a significant factor taken from this research. There's another research study was done in the Spine Journal in 2000, published in 2015. They say patients with Cauda equina syndrome incomplete have a 5 times improvement of the bladder function in 24 hours contrast to 48 hours surgery. So the decompression surgery for the patient with Cauda equina syndrome retention have no difference between 24, 48 or 70 hours, whatever it is. There is no improvement, there is no difference outcome in this Cauda equina syndrome retention. That means the later group or delayed group. This supports the theory that is the severity of the bladder deficit at presentation that may be determine the outcome. So what is a incomplete, suspicious, incomplete having a good outcome, but its retention, if we do even early, it will not give a good outcome according to this study. So what we are thinking, best outcome of the decompression of Cauda equina syndrome is obtained by operating at the earliest as possible. All right. So we have seen how they present and how they quickly we attempt and how we are going to do surgery as early as possible. If the patient present late, are you going to operate? These are big questions, because like our countries, most of the times the primary care practitioners or physicians or GPs miss the Cauda equina syndrome in initial presentation. So they will come after 10 days, 12 days, or sometimes patient come after a month. So for that patient, what we are going to do? So this is a European Spinal Journal in 2011. They have done a study in developing countries or about these Cauda equina syndrome. They found a very strong positive correlation between the delay in the surgery and the duration of the recovery. The suggestion that those group patients who present late would be definitely benefited by decompression. Even though they are coming 12 days, even though they are coming 2 weeks, still they will get benefit if you do the surgery. That is the taking point from this study. So what we are doing, even though they are coming delay, we have to act as urgently, and we have to do the surgery as early as possible as we can. That will give better outcome rather than if we are delaying the surgery. So still decompression patient with presenting late gives some meaningful improvement at a period of considerably longer than the counterpart. Right, now we are coming to the final part of outcome. So this consists of post-operative care and the recovery. So in the post-operative care, what are the things we have to consider? So we just concentrating on the surgery will not help to improve the outcome of Cauda equina syndrome patients. We have to manage postoperatively, and we have to follow up the patients. So in the postoperatively, we have to immediately mobilize the patients if their neurology is normal, or if they're having a partial neurology, we are trying to mobilize with a lot of physio support. And the pain management is very, very important. We have to give paracetamol 6 hourly. That is give a lot of pain reduction, but normally we are not using any neuropathic pain medications or NSAIDs in postoperatively. The next thing is a bladder issue. So all the patients before surgery, we are catheterizing, even though irrelevant to patient having a bladder symptoms or bladder function is very good, whatever it is, we are catheterizing all the patients. In postoperatively, we are doing tweak. That means we are doing a trial of catheter if they're having a sensation of the trigone, and we are doing sometime flip flow and check the sensation, then everything's fine. We are removing the catheter. If fail to remove the catheter, what we can do is we can do continuous follow-up of catheter or intermittent catheterization. This all can be done under urologist follow-up. So next one is a bowel function. So most of the patients come with a constipation, so we have to give the laxatives and other bowel care like manual evacuations or daily stimulations. All this has to be done in a special care practitioner in the ward, and we have to plan the bowel care when we are discharging the patient as well. The next thing is a sexual function. So the patient feel very depressed because of the sexual issues and the future, what will happen, and we can educate the patients about that. And we have to get a psychological advice and psychiatric referral to the patients to get some ideas about the rehabilitation. So this is what we have discussed in acutely we can do in the ward setup before discharging the patients. And generally, if you see the recovery, this is unlike other type of neural injury. The recovery of the bladder and sexual function may continue for a number of years after an insult. So this is a disaster. So there's unlikely due to neural regeneration, but patient probably adapt, and they will develop ability to compensate the strategy to coping with bladder and sphincter denervation. The length of follow-up is therefore an important variable. So the recovery of the sexual function appears to mirror of sphincter outcome, particularly in the woman. If you're seeing where incontinence during the sexual intercourse is emotionally distressing and adds to that problem causing lack of perineal sensation as well. The perianal anesthesia is persistent in nearly half of the population, even at the long follow-up. So we'll come to the end. So what we have seen up to now, first thing is the Cauda syndrome is a medical emergency. And even though it is very rare, it will cause serious morbidity to the patient. So diagnosis of Cauda syndrome is very difficult because there are no specific clinical features or investigations. Thus, we have to make diagnosis with clinical assessment, bladder scan, and MRI together. The management is surgical decompression, and timing of surgery will determine the outcome. Not only concentrating the surgery alone, but also we have to concentrate the post-op care, because that is the one give a long-term outcome, and we have to assess long-term, and we have to support the patient to come out from the morbidity. So for the take-home message for the primary care practitioners, when the patient comes with a lumbar back pain or lower back pain with the sciatica, we have just asking some quick questions about bladder bowel function and any perianal numbness to exclude the Cauda syndrome is crucial to diagnosis of Cauda syndrome. Thank you.
Thank you, dear sir, for your very informative lecture. And I'm seeing some questions in the chat box, and have received some questions which were submitted before the lecture as well. So let's go to the first question. Many of the questions we have already answered. Now there's one question in the chat box. What's the role of steroids like dexamethasone in managing Cauda syndrome?
So the steroids, if it is an acute Cauda syndromes, we are normally not using the steroid. So example, sometimes maybe in a tumor, especially in the tumor or chronic Cauda syndromes, yeah, definitely yes. Otherwise, normally not practicing dexamethasone.
Okay, sir. Then there's another question. What can we advise on prevention for patients who are susceptible?
So this question is a little important. The thing is, actually, we can't prevent the Cauda Equine syndrome, because if they already have the susceptibility to the Cauda Equine syndrome, we have to advise whether it's developing or not. And we can advise about what I mentioned in the safety netting. We have to tell the patient these are the risk features are there. Then if that present, then you have to come immediately. But some other cases, like patient having a big disc and sciatica, definitely we can go ahead with the surgery and we can prevent like that. And if it is a bleeding tendency to the patients, then we can ask them to avoid surgery. But these things are mainly advised by the healthcare practitioners, not in patient hand. So we have to know about the risk of the Cauda Equine syndrome, so we can try to prevent that. I think this is mainly has to be done by the healthcare practitioners rather than the patient.
Thank you, sir. There's one more question. How to differentiate Cauda equina and conus medullare syndrome by examination? That's a question we received before the lecture.
Yeah, so the conus medullaris is a end of these spinal cord, isn't it? It's a conus medullaris syndrome is coming from T11 to L2 or L1. So this conus medullaris syndrome having like a spinal cord injury features plus Cauda equina syndrome features. So it's a transient zone. So patient having a upper motor neuron lesion plus lower motor neuron lesions. But study says that the conus medullaris syndrome having more affection in the sexual function and the perianal sensation. So that is little different, but the management is same. We have to decompress. The management is same, and finding and clinical findings are a mixture of these upper and lower motor. Or even the conus medullaris syndrome present acutely, it will be like Cauda equina syndrome. Then later on, we can see the upper motor neuron lesion, isn't it? If it is in the shock, we can't see the upper motor neuron lesion. So that is the major difference.
That's all for today, sir. Other questions we have received, you have already answered in your lecture. So I would like to take this opportunity to thank Dr. Balakumaran Thangarajah for his very valuable lecture, which is a very important topic, but it is we are not encountering as much patients as like other diseases in our clinical practice. So it is very important lecture today we got, and we can save someone's life. So again, I would like to thank Dr. Balakumaran Thangarajah, consultant orthopedic surgeon, District General Hospital, Trincomalee, for his valuable lecture. And I invite all of you to join with us in the next week as well with another important topic. And the link for the e-certificate is posted in the chat box. Kindly follow it to gain your CBD points and the e-certificate. Thank you very much.
Thank you very much for everyone. Thank you very much, Sri, for giving opportunity to present this case in all of the audience. Thanks.